All right, grab your stethoscope and let's get ready for our shift. Welcome to today's Explainer, where we're going to walk through the PCA clinical dashboard. I want you to think of me as your mentor today. We're going to cover vital signs, legal boundaries, and exactly what to do when things escalate at the bedside. Consider this our shift briefing before we step into the patient's room. Today, we've got 5 key things on the agenda: the rules of delegation, measuring core vitals, tracking blood pressure, oxygen, and the fifth vital, and finally, your role in the ecosystem. Okay, let's dive into this. Imagine we're standing in the hallway, right outside our patient's door. Before we even touch the patient, we need to talk about Section 1, the rules of delegation. Notice the fundamental boundary of your practice here. A certified nursing assistant, or CNA, operates under clinical and medical state laws. For them, taking vital signs is an automatic duty, it's a right. But as a personal care aide, or PCA, your scope is non-medical and custodial. You're employer regulated. This means taking vital signs is a privilege. It is a delegated task only, and it absolutely always requires RN oversight. You literally cannot just decide to take your patient's vitals on your own. So how do you actually get that privilege? Well, you have to pass through what we call the RN delegation sequence. Think of these as 3 strict gates you've got to clear. Gate 1 is the patient stable. If they're critically ill or their condition is rapidly changing, delegation stops right there. Gate 2, are you, the PCA, actually trained and competent to perform this specific check? And Gate 3, are the parameters perfectly clear? Meaning, do you know exactly how often to check and how to report it? Once all 3 of those gates are cleared, boom, delegation is granted. But definitely pay attention to that red accountability link. The RN retains ultimate legal responsibility for that patient, so you must follow their exact instructions. Before we open that door, I want you to memorize this Master Vital Signs Matrix. It is essentially your ultimate clinical cheat sheet. We're going to be referencing this a lot. It outlines your normal ranges and, most importantly, your rapid escalation triggers for temperature, pulse, respirations, blood pressure, oxygen, and pain. Lock this into your memory. All right, it's time. Let's walk into the room, approach the bedside, and start Section 2, measuring core vital signs. We're getting hands-on now. First up is temperature, and there is a very strict hierarchy to how we measure it. Oral, under the tongue, is your standard go-to, provided the patient won't bite the thermometer and hasn't had hot or cold food in the last 5 minutes. Tympanic, the ear, is electronic and rapid. Just make sure you use that plastic sheath. Axillary, or the armpit, is your least reliable method. Honestly, only use it if the first 2 are absolutely impossible. And then look at the strict protocol at the bottom. Rectal. You never, ever take a rectal temperature without explicit, direct approval from an MD or an RN. No exceptions. Moving to the pulse, I really want you to feel this. When you check the radial pulse on the wrist, place your first 2 fingers straight down from the patient's thumb. Never, ever use your own thumb. Why? Because your thumb actually has its own pulse, and you're just going to end up counting your own heartbeat. Count for a full 60 seconds. Our normal range here is 60 to 100 beats per minute. If it's below 60, above 100, or if the rhythm just feels irregular, that is an immediate escalation trigger. Now, right after you count the pulse, you move directly to respirations. And here's where we use the stealth technique. Keep your hand on their wrist as if you're still taking their pulse, but shift your eyes to their chest. You're visually counting respirations without the patient even knowing it. Why do we do this? Because the second someone realizes you're watching them breathe, they unintentionally alter their breathing pattern. So just silently watch the chest rise and fall. 1 inhalation plus 1 exhalation equals 1 breath. Alert the RN if it's below 12 or above 20. Great job on the core vitals. Let's move on to Section 3, tracking blood pressure. Keep in mind that for a PCA, this specific task enters a special category. It is informational only. Before we take a reading, we need the right gear, and it needs to be calibrated properly. Focus on the device hierarchy here. The upper arm cuff is our gold standard for accuracy. Wrist cuffs? Those are just an alternative if the arm is too large or maybe for specific medical reasons. But pay close attention to that red X. Finger devices are absolutely forbidden. Clinical guidelines explicitly reject them because they're just terribly inaccurate. Also, keep the size rule in mind. A cuff that's too short gives an erroneously high reading, and a cuff that's too large gives an erroneously low reading. Now, what's really interesting about this is what those 2 blood pressure numbers actually mean inside the body. The top number, the systolic, is the pressure when the heart is actively contracting. That is the very first beat you hear when you release the valve. The bottom number, The diastolic is the pressure when the heart is at rest, relaxing between beats. That's the last beat you hear. As a PCA, your role is to accurately collect these two mechanical data points and pass them right along. And here is where you must be incredibly vigilant. If you get a reading under 110/60 or over 140/90, you report it immediately. But listen, it's not just about writing down numbers. It's about observing the patient. Are they complaining of a sudden headache or maybe a nosebleed? That's a high blood pressure symptom trigger. Are they dizzy or feeling faint? Well, that signals dangerously low blood pressure. These are clinical danger zones, so stay sharp.
We're doing great. Let's continue our bedside practical by introducing the final critical checks of our patient observation in Section 4, oxygen and the fifth vital.
Just like blood pressure, measuring oxygen saturation with a pulse oximeter is informational only for your scope. A normal reading for a healthy adult is 95% or higher. But remember, the machine is just a tool. It's your physical observation of the patient that is truly critical here. If their oxygen drops, they enter a state called hypoxia. I really need you to watch for these physical cues carefully. Visually, look for cyanosis. That's a bluish tint to their lips. Listen to their breathing. Are they suddenly experiencing shortness of breath? And critically, check their cognitive state. A sudden onset of confusion or an altered mental state can be a massive red flag that their brain just isn't getting enough oxygen. These signs require immediate, urgent escalation. Next up is what we call the fifth vital sign, pain. Our core principle here is simple. Pain is an unpleasant nervous system signal. It is not a normal part of aging. I'll say that again. It is not just a normal part of getting older. Whether it's acute pain from a sudden injury or chronic pain they've dealt with for a long time, it is your responsibility to report it promptly. Detailing the location, the intensity, and any nonverbal cues is absolutely essential. But how do we measure pain when every single patient communicates differently? Well, here's your pain assessment toolkit adapted for every scenario. If the patient is verbal, just ask them to rate it from 0 to 10. Super simple. If they're visually or cognitively impaired, like a child over 3 or maybe an adult with dementia, use the FACES scale and have them point to how they feel. And if they're completely nonverbal, that is when your observational skills really shine. Score them based on facial cues like frowning, restless movement, or guarding their body. You've got to adapt your method to the patient sitting right in front of you. All right, our bedside observation is complete. Let's step out of the room, head back over to the nurse's station, and debrief. It's time for Section 5, your role in the ecosystem. And this brilliantly illustrates what we've been doing this whole time. As a PCA, you are the sensor. Your job is high-fidelity data collection. You observe accurately, you measure precisely, and you report instantly. Your output is raw data. The registered nurse, on the other hand, is the processor. Their job is clinical analysis. They take your data, combine it with the patient's medical history, and make a diagnosis. The golden rule? PCAs collect, RNs interpret. Never cross the line from sensor to processor. Because if you do cross that line, you are going to hit these 3 red flags of liability. Number 1, practicing outside your legal scope. Number 2, operating without the legal backing of the RN or the facility. And number 3, the absolute most serious. You become personally liable for any errors, misreadings, or missed escalations. It is a huge deal. Consider this your final system warning. Taking vital signs without explicit RN delegation is a critical breach of protocol. Your ultimate safety net is simple. If you are ever in doubt, ask the RN. Your greatest clinical tool isn't the thermometer or the blood pressure cuff. It's your own power of observation and your ability to communicate what you see quickly and clearly. So as we wrap up our shift briefing, I really want you to think about the incredible importance of your role. You are the eyes and ears at the bedside. Are you ready to be the critical, high-fidelity sensor in your patient's care ecosystem? Take these tools, stick to your scope, and you are going to be absolutely exceptional. Thanks for joining me for this explainer, and have a fantastic shift.